Okay, we're going to get started. Hello everyone, I'm Greg Melhoff and I'm the Deputy Director of the California Prevention Training Center here in Oakland. Welcome to the first of a series of webinars that are sponsored by the State Office of AIDS Prevention Branch. There'll be 4 total. It's in collaboration with the Pacific AIDS Education and Training Center, otherwise known as the PAETC, and the California Prevention Training Center here, CAPTC. And we have the Curry National TB Tuberculosis Center also helping us with producing the webinars with their technical assistance today. So thank you, Jeannie and Amelia. All 3 of the training centers have a national and in some cases international focus, providing training and TA to public health, CBOs, private healthcare settings to increase the capacity of public health workforce in HIV, STD, and TB programs. We have collaborated for many, many years, so it's nice to collaborate on this, and we find that our training audiences cross over much more than they used to. And one of the future webinars will talk a little bit more about that. Before we start today, I just want to cover a few housekeeping items. First of all, we're recording this session, so we want to be able to record it and have it available to you who are listening in to review later, and also for people who weren't able to make it to also listen to it in the future. It'll be available on our website at CAPTC and the PATC website in the future, and we'll let everybody know when that's available. So as you noticed, we didn't allow people to dial in on the phone, so we're going to use the chat box, and I see some people are already using the chat box, and we're going to take questions through that form. We're not going to let people ask questions directly. So I'll be monitoring those, and then we'll get them to the presenters to answer towards the end of the session. Anything that we don't get to cover, we will then send out the responses later to everybody who has registered. So for a little bit of practice using the chat, if you want to, please, if you're sitting in a room with multiple people, please just type in the number of people that are sharing the room with you in the chat box, because that gives us a better sense of the reach of the webinar. Thank you for doing that. If you need assistance, you can go up to the top of the screen and you'll see a little person with a hand raised, and you can raise your hand. We'll be monitoring that, and we'll send you a private chat to check in with you instead of interrupting the entire session. So we'll check and see what we can help you with there. If you're experiencing a delay in slides advancing, that is probably a slow internet speed at your setting. Generally, the audio will continue and the slides will catch up. So there's nothing we can do about that on this end. So hopefully it will be fine. So as I said, this webinar series is 4 webinars, and it's going to continue through February. And we're addressing current topics that are relevant to HIV and STD prevention programs. This particular webinar highlights the connection between STDs and HIV, underlining the importance of effective STD screening, so we're catching all of the disease that's out there, and the connection with how that reduces HIV transmission. And we'll talk a bit more about that later from our presenters. Following this, the next webinar is about PrEP navigation, and it's going to include the introduction of a new tool developed by the Project Inform. That's a PrEP navigation manual for programs to help implement PrEP. And then later and also with that, some updates about what new things are coming in the way of PrEP, some really exciting things coming up. Following that will be the changing role of DIS, how DIS, disease intervention specialists, are used in broader context in health programs, and that speaks a little bit to what I was saying about the overlapping audience of the 3 training centers. And then the final webinar in February, we currently are holding it to address any changes in ACA that may come between now and then. If there are no changes, what we may do is substitute another timely topic there, but we just don't know what's going to happen. So today we're going to hear from the team from Orange County Healthcare Agency, their STD HIV clinic, which is known as the 17th Street Testing, Treatment, and Care Clinic. And they offer testing and treatment for most STDs, such as syphilis, gonorrhea, and chlamydia, HIV testing, HIV medical care, information and education on STD and HIV prevention and treatment. They administer ADAP and provide ADAP, and prevention services such as PrEP and condom distribution. So they've been working for quite a few years conducting extragenital or site-specific screening, and they recently been participating in a program funded by the Office of AIDS Ryan White Part B Clinical Quality Management Program, and Dr. Reed will mention that a little bit in the presentation. The Prevention Training Center has also been working with a number of agencies under that same program. So the team in Orange County consists of Dr. Christopher Reed and Danielle Farias-Connor, MPH, and who will both be presenting today, and other important team members who are in the background and have contributed are Colleen Brody and Alyssa Haberman that work in the clinic there. So Danielle is going to start the presentation, and I'll let her tell you a little bit about herself, and then she will introduce Dr. Reed. Take it away, Danielle.
All right, great. All right, hi everybody. My name is Danielle Connor. I'm a State Office of AIDS Research Analyst. I'm contracted to work in Orange County, so technically I work under Office of AIDS Prevention Branch, but here in Orange County I work by assisting with data management, program evaluation, and statistical support. And I think technically I'm under the Data to Care unit up in OA. And Dr. Reed?
I'm Dr. Reed. I am the medical director of HIV STD services for public health services in the healthcare agency. I started my career in '91. For about a decade, I did nothing but HIV. I'm an internist by training. And after a decade of HIV, I came to Orange County, took over the STD HIV program, and became the STD controller. Okay.
All right. So our presentation today is called STDs Missed Opportunities, Implementing Site-Specific Screening. So our objectives for today are gain an understanding of the rationale for site-specific screening based on published and local data, gain an understanding of the best practices for implementing site-specific screening, gain an understanding about how to promote site-specific screening to providers and patients, and learn how to conduct an effective sexual risk history in a sensitive manner. Our roadmap today, just so you guys know the organization of this presentation, we're going to first define site-specific STD screening, discuss why it's important, show you some of the data, our epidemiological overview to support why it is important. We'll talk about STD screening as HIV prevention, as well as STD screening in people living with HIV. Dr. Reed will again go into effective and sensitive sexual health screening, as well as some barriers that providers may face in doing effective sexual health screening. And then we'll talk about some methods that we've used in our clinic for implementing site-specific testing. So first, what is site-specific testing? So it's sexually transmitted disease screening at anatomic site of exposure. So if a client comes to you and tells you that they engage in anal sex or anal rectal intercourse, the appropriate screening would be rectal screening for gonorrhea and chlamydia. Same with oral sex. If a client says that they engage in oral sex, then the appropriate screening is pharyngeal screening for gonorrhea and chlamydia. It is recommended by the Centers for Disease Control in the 2015 STD treatment guidelines for all men who have sex with men, regardless of condom usage as indicated by the client. Site-specific testing, you may have also heard it called extragenital testing. So I don't know if anybody else had to take Latin in school, but extragenital, extra outside of your genital area. It means testing sites other than the penis in MSM, which is done via urine testing or urethral swabs. You may also hear it referred to as multi-site testing, which means testing more than just urine for exposure to gonorrhea and chlamydia. It could also, in women, it could include vaginal swabbing as well. So why is site-specific testing important? The most important factor is that it identifies STD infections that are missed by urinalysis alone or urethral swabs alone. And we'll show you some data as to why that's so important and how much infection we are really missing. It ensures that your STD screening reflects the sexual practices of the clients that you serve. As site-specific testing provides an opportunity for high-impact HIV prevention, such as referrals to PrEP and other risk reduction activities. It's also an opportunity to really provide quality sexual health and primary care for your clients who are living with HIV. This is something that gets deprioritized a little bit when treating people with HIV, as we'll hear a little bit more from on Dr. Reed later on. So our first polling question, before we get into the data, we want to test some knowledge here. How much gonorrhea is missed when only urine specimens are tested in MSM? And we have 25%, 50%, or 95% of their options. All right. Looks like the majority of people are saying 50%. Okay, so let's see if I can get back to my slides here. Okay, so the correct answer is actually 95%. So this data comes from San Francisco. This is the proportion of chlamydia and gonorrhea infections missed among asymptomatic MSM. As you can see, we miss up to 95% of asymptomatic gonorrhea cases, as well as 70% of asymptomatic chlamydia. So moving into some national data, this data comes from the STD Surveillance Network. It's a pretty hefty sample size, almost 22,000 MSM clients are included here. And this just shows the proportion of positive site-specific tests that occur concurrently with negative urethral tests, and that's either urine swabs or urine sampling or urethral swabs. So as you can see, 74% of pharyngeal gonorrhea and 72% of rectal gonorrheas are positive alongside a negative urethral sample. 92% of pharyngeal chlamydia and 88% of rectal chlamydia are positive concurrently with a negative urethral. So that's pretty significant statistics there. And then just to hit this point home one more time, this data again comes from San Francisco, and this indicates that the majority of rectal infections in MSM are actually asymptomatic. So we know that many cases of gonorrhea and chlamydia disease are asymptomatic and therefore can be underreported, but site-specific screening really provides more accurate disease reporting. Obviously, if you identify these asymptomatic infections before somebody comes in with a burning or discharge, you're going to see higher incidence and prevalence numbers for your area, but 86% of these infections were asymptomatic chlamydia and 84% asymptomatic gonorrhea. All right, so moving into some of our local data here for Orange County. These numbers come from our categorical STD clinics. So our STD clinics use about 10,000 visits per year. These numbers here included are just for MSM clients who we saw. This data is about a year old. And these are clients who had at least a urine test and one other site tested. So it could be urine and pharyngeal. It could be all three sites. So as you can see here, these tests were ordered, about a third of tests ordered were rectal, throat, and urine samples. but rectals contributed the majority of positive chlamydia here. So 70% of the positives in this sample came from rectal specimens. So this indicates that rectal chlamydia samples had a 15% positivity rate compared to just 3% for urine and 2% for throat. So while fewer rectal tests are being ordered, they are more likely to be positive than tests from other sites. Moving on to some gonorrhea numbers from our STD clinic. Again, same sample here. Because these tests are paired tests, that we test these together. So same proportion of tests ordered, 30% rectal, 30% from throat, and 35% from throat, and 35% from urine. But our rectal gonorrhea numbers indicate that this contributed 42% of all positives, throats contributed 37% of all positives, and urine samples contributed 21% of all positives. So the positivity rate for rectal gonorrhea was 13% compared to just 10% for throats, and as little as 5% for urine samples. Now moving on to some data from our HIV clinic. So again, same time frame here. This data is about a year old. In our HIV clinic, we serve only uninsured clients. We have about 700 HIV clients, and the majority of whom are MSM. And these, again, are MSM who've had urine tests plus one other site tested. So in our, you can see there's just 200 samples included here, so a smaller sample size, larger contribution of each data point. But 28% of the tests ordered in this sample were rectal tests, 26% were throat samples, and then 46% were urine tests, so a lot more urine here. But as you can see, 54% of all positives actually came from our rectal specimens, compared to just 14% of urine, and 32% of positives actually came from pharyngeal samples, which most people don't think of there being high prevalence of pharyngeal chlamydia, but we've seen in our clinic that it's definitely a test that is worth performing. So our rectal samples have a 19% positivity rate. Our pharyngeal samples had an 11% positivity rate compared to just 2% for our urine test. And finally, the last little piece of data that I'm going to throw at you here is our gonorrhea rates from the HIV clinics. So again, rectal exams rectal specimens made up just 21% of all tests ordered, but contributed 50% of the positives in this sample. Pharyngeal tests were 22% of all tests ordered, but made up 33% of positives. And then urine tests were 55%, so the vast majority of tests were urine, but contributed just 16% of all positives here. So rectal gonorrhea had a 22% positivity rate, pharyngeals had a 13% positivity rate, and urine samples just a 2% positivity rate. So now I'm just going to turn it on over to Dr. Reed now that we've gone through some of our data.
Okay, so first thing I'm going to cover some information about the link between STDs and HIV. Really, virtually all of the STDs can increase the chance of acquiring HIV if one is exposed to HIV, because being exposed to HIV doesn't mean you become infected, you have a risk of acquiring it. So you can think to yourself, it's quite logical that if you've got an open sore on your penis, in your mouth, in your anus or rectum, very easy for HIV to get into the body through the open sore. And when you have other STDs that cause an inflamed rectum, and inflammation in the throat, inflammation in the penis, because of the STD infection, all the white blood cells, of course, go to the site of infection in your body and try to fight it. And some of those white cells that go to that site are CD4 cells, which are the cells that HIV infects. And so if you imagine if all the CD4 cells are going to the site of the STD infection, and there's a little bit of HIV there, CD4 cell can attach to the virus and the patient becomes HIV infected. And also, if you have open lesions in the throat or an STD in the throat, we think that HIV transmission via that route is made much easier. Now, second polling question. So, what is the potential risk for an MSM with rectal gonorrhea to be diagnosed with HIV within a 12-month period? So what we've got is an MSM, he's got rectal gonorrhea, he's HIV negative, but what is the chance over the next 12 months he would become infected with HIV? Is it 1 in 5 chance, 1 in 15 chance, or 1 in 50 chance? Okay, I guess we wait until you say that polling is closed.
Let's give it a couple more seconds to let people respond, and then we'll close it.
Okay, polling is closed, and the majority said 1 in 5 chance. After that, almost equal over 1 in 15 and 1 in 50. The next slide does not have the result, does have the results, right? Yeah. So the answer is actually 1 in 15. So you can see this nice little easy graphic here that if a MSM is diagnosed with rectal gonorrhea or chlamydia, they have a 1 in 15 chance of being diagnosed with HIV over the next year. Primary and secondary syphilis, almost the same risk, but if the patient has no rectal STD and does not have syphilis, look how much less the risk of HIV infection is over a year, down to 1 in 53. So when we're looking at STD testing and prevention of HIV, in an STD clinic like ours, and we're the only categorical STD clinic between San Diego and Los Angeles, there's plenty of opportunities for sexual health education, risk education, and reduction during the visit itself with the medical provider, and even with nurses in the clinic who take their time to talk to patients about what they were there for and what they may need to do in the future to change their risk. The STD clinic also provides referrals to prevention programs such as biomedical prevention with PrEP. So our HIV and STD clinics are co-located. They're in the same office suite. The PrEP clinic is in the STD clinic, and we only treat patients with PrEP, doing all the labs that are required, the STD screening every 3 months, and all the paperwork to get the drug free from the pharmaceutical company to the uninsured patient. If the patient has insurance, then we refer them out to a PrEP navigator in a CBO who will help them find a provider in their network that is willing and ready to provide PrEP. Also, we have a number of public health nurses working in the PrEP program, so there's really someone there every day on call to take a patient and talk to them about PrEP, whether they're insured or not insured, to give them information about PrEP the same day. Now, other methods that kind of improve HIV prevention or ways we're doing it is, I'll talk about more a little bit later, is when we're going to provider offices, my staff going to provider offices, or the public health investigators, also called DIS, talk to medical providers in the community to really get them the information out about site-specific testing. Because as you'll see, not really being done very well, getting better, and a lot of improvement needs to take place. Because we obviously do not see the majority of men who have sex with men in our county. Orange County, surprising to many, is the 6th biggest county in the United States. And getting our docs to do proper STD screening and even proper sexual health history on patients is an uphill climb. So looking at this study, that assessed the testing of known patients with HIV who are going to see their HIV doctor. What percent were screened, I think this is over a year's time, were screened for syphilis, chlamydia, and gonorrhea. And you can see about half were screened for syphilis and less so for gonorrhea and chlamydia. And you may think, why is that? Well, syphilis, a doctor ordering a syphilis test is just checking a box on a paper in the paper or an EHR. Chlamydia and gonorrhea of the urine is so easy to order too. You don't have to do anything. As you'll see later on in the presentation, actually breaking out the swabs, talking to the patient about the swabs, and doing the swabbing is a whole other deal. Next slide. So what does the CDC recommend? Well, CDC says in the 2015 STD treatment guidelines that all MSM should be screened for HIV and syphilis, gonorrhea and chlamydia in the urethra. That's assuming they use their penis for sex, and some people don't use their penis for sex. Rectal testing for gonorrhea and chlamydia if they do anal sex, and pharyngeal testing if they do oral sex. And that's, of course, both for receptive rectal and receptive pharyngeal. Testing for hepatitis B and C, and also sometimes you might want to do serology for herpes, especially if the patient requests it. Okay, so what's going on in our program just to hang out our partially dirty laundry? So in the STD clinic, we got it down. It's all protocolized and adhered to very nicely. So if an MSM walks in our door, of course the recommendation is for high-risk MSM to be tested frequently with all these tests. But basically, most of our MSM patients in the STD clinic are high-risk MSMs for STDs and HIV. PrEP patients, it's part of the protocol for PrEP that they get tested every 3 months for STDs. So in the STD clinic, which is only 20 paces from the HIV clinic, it's in the same office suite, does a really good job of site-specific testing. HIV clinic, not so much. HIV clinic is run by all but I think 5 out of 7 are ID doctors. One's a family practice, and I'm internal medicine. Everyone's part-time except for me. We do a crappy job. In our clinic, over a 12-month period that we looked at, only 30% of MSM in the HIV clinic had site-specific testing. So embarrassing, but obviously that's why we're doing something about it and partly why we're doing this presentation. Just looking into like where do you start? So when you're in an office visit with a patient, what should the provider go over? Obviously, the provider should conduct a risk assessment. It should be done every 3 to 6 months. And if the patient is high risk, with these definitions you see listed here, multiple anonymous partners, using drugs, especially crystal, meeting partners on the internet, having sex partners who do some of the things above, basically virtually everyone, almost all the MSM we see, we recommend come every 3 months. If the risk is lower and the number of partners is lower, certainly you go for a longer period of time. But remember in discussing screening with patients that if you say I have anal receptive sex but there's a condom on the penis in my butt 100% of the time, that's lovely and wonderful. We love you for using condoms, but I'm still going to swab your rectum. And that goes for oral sex as well. Of course, no one uses condoms for oral sex, as you know. Anyway, so in the sexual history and risk assessment, you find a lot of valuable information, the most important of which is how high risk is the patient for acquiring STDs and HIV, but also you know where to put the swab or what orifice to check. And a little note here that in the providers who knew that their patients were MSM, because we'll go over a little bit of doctor-patient communication problems, the doctor is much more likely to recommend HIV testing or Hep A or B vaccination. So some of the bad news. This is not data from us specifically, but more national type studies. In patients being assessed by their medical providers, almost 40% of the patients, MSM patients, who see their medical provider don't even tell them that they have sex with men, probably because the doctor didn't ask. In HIV-infected patients, 75% of them say that they didn't discuss reducing transmission risk with their providers, which is very shocking. And only 6% of HIV-infected patients discussed what kind of sex they had with their sex partners with their primary care doctor. So there's not a lot of good communication going on here. You need to know what orifices are being exposed to STDs and HIV in order to test the patient and, of course, assess them for a risk of other STDs, HIV, and hepatitis as well. Okay, so this is from the MSM toolkit, and some of the previous slides were too, and I should mention that that is not something we created. Lovely document created a while back, revised a couple of years ago, CDPH and what was then called the California Prevention Training Center. When you're talking to patients about, I'm not going to read all these items, you probably know this well, but just to kind of know what we do, we basically have our providers say to all patients, no matter what they look like, no matter how old they are, young they are, ask everyone, do you have sex with men, women, or both? And then later in the interview, there's a question about having sex with transgender women or transgender men. How many partners do you have? Where do you meet them? Internet or app. Acquired partners have higher risk of acquiring STDs. And do you know if your partners have STD symptoms? Do you know their HIV status? The next important item to cover when you're talking to your patients about sex is, do you have anal sex? Do you have oral sex? But the problem is we've had these terms over the years that are just confusing as all get out. Are you the insertive partner? Are you the receptive partner? Are you active? Are you passive? I like to think of, and I don't know it well, but there's something called Where's Waldo? Well, is it Waldo? Okay. Yes. So I'm saying, where is the penis? Where is your penis when you're having sex with your partners? Where is his penis? How many different penises have you had in your butt since I last saw you? How many different penises have you had in your mouth? How many different rectums have you put your penis in? I mean, it sounds silly, you may think, but when you make it so simple, there's no confusion at all. And I tell you, it's very difficult sometimes to do these other kind of receptive and sort of active, passive terms when you're talking to an immigrant from Mexico, which we have plenty in our clinic, recent immigrant, and there's so much confusion. Get to the, go to the money, make it as clear as possible. Are you having more sex? Do you do different things with different partners depending on your HIV status? But this is critical, obviously, because receptive anal sex, which is the highest risk activity really for our patients, you need to know where to put the swab and where to test the patients for STDs. So obviously we don't want to ignore the fact that the risk of acquiring HIV is higher also in our injection drug users. They want to know about the risks associated with that. Are they using sterile equipment? Have they been tested for hepatitis C? Do they need vaccination for A and B? And have they been tested for HIV, of course? So why does it appear that many places are doing a poor job in screening MSM? Well, we are more and more a very diverse country, ethnically, socially, but the sexual mores of our clinic, for some reason, have remained Victorian. We don't like talking about, doctors don't like talking to the patients about sex. Patients really don't like to talk to the doctors about sex too much. They want the doctor to bring up the topic. And the doctor is not going to bring up the topic because he's uncomfortable talking about it. The patients are uncomfortable having their genitals examined and their anus examined just because, not a lot of people look at those areas of their body in the course of their life. It's uncomfortable, and the lack of knowledge among patients and providers for doing site-specific testing of the throat and rectum is, there's so much lack of knowledge. You think providers, certainly many of them don't know they should be testing throats and rectums, but patients will come in, like I saw a guy just 2 days ago, oh no, I went to Planned Parenthood, they checked my urine, they drew my blood, they said I had a complete STD exam and I'm clean. And I said, well, do you ever have penises in your mouth or in your rectum? He's like, oh, every time. I said, did they swab your throat or your butt? He said, no, they never do. Well, there's a lot of patients out there that need education as well. You'd be surprised. It's probably equivalent among doctors and patients almost, I would say, that the lack of knowledge. So another barrier is doctors think it's going to take too long. I got too much to do. There's 6 more patients waiting. I can't do this because it's going to take too long. Other things that kind of interfere with a real good health screening for MSM and testing for gonorrhea and chlamydia is all this gonorrhea and chlamydia testing we've been discussing is all called NAT testing. I don't know if you've heard the term, but it's nucleic acid amplification test. And that testing is an approved test by the FDA for many, many years. But after all these years, I don't remember how many years it is, maybe 15, 20, it's been a while. It's still not approved to use that test in the throat or the rectum. You can do it, or in other words, a lab can do the test on specimens collected from the throat or rectum, but they have to do a test first to validate it because it's not FDA approved for that site. So they can do a validation study, and then they can accept specimens from those sites. Now, the big labs in California, Quest and LabCorp, and there may be other big labs I'm not aware of, but they all accept pharyngeal and rectal swabs for gonorrhea and chlamydia testing. Smaller labs could do the validation testing themselves, and of course our public health lab did it a number of years ago so that we could use NAT testing, which is a great test for finding gonorrhea and chlamydia, much better than what we used to do, which is culturing, on a plate. And another issue is some health plans may cover only one gonorrhea chlamydia test per visit. And I've been working a lot with Planned Parenthood because if an MSM goes into Planned Parenthood, and I'm not sure why MSM go to Planned Parenthood for their STD testing, although it's I think the first Google search item that comes up if you Google STD testing nearby. Frequently with Family Pact, which is usually what the patient is covered by when they go to a place like Planned Parenthood, they can only do one test. And if they're having receptive anal sex and receptive oral sex, testing their urine is not where the money is. I've talked a lot with the medical director of Planned Parenthood, and I say go for the butt. Always go for the butt. If you're going to do any test, if the patient does oral and anal and uses his penis for sex as well, test the rectum. Always test the rectum. Now, as far as self-collected specimens, which is what we're in the process of implementing now at our clinic, the CMS, or the Center for Medicare and Medicaid Services, regulates lab testing throughout the country through something called CLIA. You may have heard of CLIA certificates. Nonetheless, CLIA is a Clinical Lab Improvement Amendments. Anyway, so validation studies can be done so that the lab can meet CLIA requirements for specific testing, such as self-collected specimens. So if a lab and a facility get together and do a validation study, they can do self-collected gonorrhea and chlamydia NAT testing as long as the validation study showed that the patient and the provider were pretty much equivalent in how well they tested the accuracy of their testing. And then if the validation study is completed in a good way and the testing seems equivalent, then the lab can accept specimens from any licensed provider. So the validation study for self-collected isn't a lab clinic specific relationship study. It's really to allow the lab to accept specimens from any licensed provider. So it's a little funny thing we looked at in Orange County. I should have probably put this earlier in the presentation, but we looked at we don't really know how many docs are screening rectums and throats, but if they're looking in the throats and rectums of patients, and this is about rectal gonorrhea, we know they must be seeing MSM and must have some knowledge about multi-site testing. You can see back in 2013 when we first looked at this, we noticed other than our STD clinic, only 6 other people in the county, doctors or clinics, were reporting any rectal gonorrhea, and we were reporting or finding 93% of the cases of rectal gonorrhea in the county. Pretty bizarre. I am quite certain we are not seeing 93% of the MSM who have rectal sex in the county. It got better. I think every newsletter I put out to HIV, STD providers, and actually, no, it goes out to all providers in the county, all medical doctors. There's always a little blurb about, don't forget to swab the throats and the butts, And it's improved. You can see the numbers have gotten better. Kind of seems to lag between 2015 and 16, but I'm hoping that we will be reporting less, and doctors in the community will be reporting more, knowing then that they're looking for it more. So if one is going to do site-specific testing, well, obviously, you could just have the provider swab the patient's throats and rectums, depending on if that's a site of exposure. And then, the patient can self-swab, where the patient's given a kit and taught to swab their own throat and rectum, in addition to giving urine. So quick question. So when one looks at these studies in our study, and you want to know, is the patient's results, so hard to read that, the patient's results from swabbing themselves vis-a-vis the provider's results, are patient swabs as good as the provider swab, better than the provider swab, or worse than the provider swab? And so put in your answers. Looks like we're going to as good. Okay, it's closed. So, wow, you guys you know what you're doing already. So it's 75 and 15, is that 15? Mm-hmm. So 90% of you think that patients are as good or better, and actually the answer is as good or better in our study so far. All the patients and provider swabs have matched except for 2, but in the 2 that didn't match, the patient found disease in their throat and the patient found disease in the rectum that the doctor failed to find with their swabbing. So patients do a better job or as good a job than doctors. Next. So a little bit about what we're participating in here that we discussed earlier is the ESS Project, or Extragenital STD Screening. So part of the project, really not the major focus of the project, but part of it really has to be validating self-collected specimens, because the project focus is really to get the HIV clinic patients who need to be screened appropriately at the sites where they're exposed to STDs better than what I showed you on an earlier slide. It was only 30% of patients who had rectal and pharyngeal screening, so we want that to get better. Very grateful that the project is being conducted with support from the Office of AIDS, Ryan White, Part B Clinical Management Program. I'm very glad to be working with you guys. And after we validate, finish the validation study, which shouldn't be much longer, we're going to be able to offer self-swabbing as an alternative to provider swabbing MSM clients. Now you may say to yourself, oh, you know, I can do it every time. Is the doctor ever going to do it? Is the doctor going to examine the patient still? We haven't written the protocols yet. I'm a firm believer in physical exam of patients. The number of times we have found a syphilis lesion, be it primary or secondary syphilis in a patient, and the patient had no idea they had a lesion or a sore or a rash, It's quite a few. So we want to still look at our patients, but we can speed them up out of the clinic if they swab themselves. And then patients in the HIV clinic, perhaps, who are only being seen every 6 months or so because they're doing so well, but they really need STD screening every 3 months. Instead of burdening the system and the doctor time and nurse time, et cetera, with another appointment in between the 6-month visits, the patient can come in, give 2 swabs, swab, urine, blood draw for syphilis, and you're out the door. So how are we doing in the project? So far, we're going to have 81 MSM. So far, we've got 81 MSM clients. We're using both clinics to do the validation. We give the patients instructions in English and Spanish. And when the provider's doing the swabbing, they kind of talk to the patient and teach them like what they're doing, and this is how it should feel like when you do it yourself, and you know, how to break the swab and keep it in the tube, put the tube on tight, the top of the tube on tight. And preliminarily, it looks really good. Like I told you, patients in our study look a little better than doctors, perhaps. And this is consistent with studies that have been, if you've seen any poster session or anything at a conference on self-swabbing, it's always about patients are always as good or better. Next one. So moving on, patients love the idea of self-swabbing, and in our clinic, it certainly makes it, if an office visit, may save provider time. These are the instructions we give to patients in English and Spanish about swabbing their rectums and their throats. And this is all in good. We can have a wonderful HIV STD clinic system where everyone's getting swabbed appropriately and wonderfully, but that doesn't help us with all the other MSM out in the community seeing private doctors. We're going to go out to those doctors that we know have MSM patients because they reported disease in MSM patients. And the PrEP staff is going to meet with them, obviously talk to them about PrEP, kind of like a drug rep going to a doctor's office. They call it detailing. Talk to them about PrEP, talk to them about site-specific testing, and as well when R&D disease investigators are following up on syphilis and HIV, et cetera, we can also provide information to them at that visit and at outreach events to patients so they get more information about site-specific testing. And that's the end. Here's, as you see the little investigator there saying, you'll find it if you look hard enough. So that's our motto. If you don't look, you won't find. And that's my email, my phone number, and Danielle's email and phone number as well. Thank you very much.
Thank you, Dr. Reed and Danielle. That was a great presentation. I'm always struck by how powerful the data about missed cases by not doing rectal and pharyngeal screening are. It's really, really powerful. So again, thank you for pointing that out and for the work that you're doing in your clinic, leading the way on this. So we did have a couple of questions. So let's quickly address those, and then people can keep typing into the chat box if you have additional questions. So the first one came from Kevin Sitter at the Office of AIDS and asking, can you record specific sites testing in your EMR?
Yes.
Yes.
So
yeah, we can collect data from the EMR on which site was tested, yes.
Okay, thank you.
Then I think we initiated the EHR May 8th, and I think there was doubt at the beginning we would be able to, but very glad to know it's all the data is all collectible.
Yes, yeah.
Okay, great. And just as a follow-up, is that, do you think that's universal, or is that your particular setting has that?
I am the worst expert in the world. I'm not even an expert on our EHR. I'm sure it's probably EHR specific.
Yeah, that's what I was wondering. So other settings may have to address that specifically for their particular records. Okay, another question was from Joshua O'Neill, and he was asking about what the source of the stats were for the slide that was indicating STDs predict future HIV risk.
I don't know if there's a...
I actually...
so that's actually a CAPTC slide.
Yes, I got the information while you were presenting, and that comes from New York City data, and it's both 2013 and 2015 surveillance data that both indicated they were consistently indicating those ratios. So that's where that came from. And I believe that's from the MSM toolkit that Dr. Reed was referring to as well, that was co-produced by the SD Control Branch and California Prevention Training Center here. So again, follow-up of the question was, is that realistic and can be applied to the context of California? And that's something that I don't believe I can answer. We can follow up with the SD Control Branch folks and see if they can provide any more specific information, or the STD and the Office of AIDS.
Yeah, I don't know what year this data was collected, but obviously in the era of PrEP, I assume this was pre-PrEP. Obviously, these numbers could be drastically different.
Yeah, so it's 2013 and 2015 data.
Yeah, it could be different now, obviously.
Yeah, it could be different now, you're right. And then we had another question from Tanya Bullwinkle, and the question is, what is the explanation for the higher rates of positive CT and GC tests in rectal and pharyngeal samples? Are pharyngeal and rectal CT and GC tests more accurate than urine tests? Is CT, GC more easily transferred to the anus or throat? Are people more often having anal receptive sex, or question mark, question mark?
Ooh, long question.
Yeah, I can break that down.
Okay, what?
Explanation, basically, what's the explanation for the higher rates, so the higher yield in the rectal and the pharyngeal samples?
I don't know if I know all the basic science behind that, and I can't say for sure that is necessarily known and has been studied. So I probably wouldn't comment. I don't want to tell you something that I'm not sure is true. Not long ago, one of my staff said, well, why are there so many bottoms coming to the clinic? Why don't we have more tops? And even that is a question. I think people that have receptive anal or receptive oral think they are at higher risk of an STD, as opposed to the person who belongs to the penis that's in the throat of the vent not coming in. So I really don't know, but certainly, as you saw with the symptomatology, whether someone has symptoms, if you have gonorrhea, chlamydia in your penis, certainly gonorrhea, I don't remember the number exactly, but the vast majority of people with gonorrhea in their penis know they have something wrong. And it's quite a big percent also of chlamydia, 40% or something. It's big numbers. So I don't know if that answers your question at all, but I think it's probably not completely known except by a lab scientist somewhere in North Carolina.
Okay, thank you. So a couple other things here while we have a few more minutes. There was a question about, are there different treatment guidelines for rectal or pharyngeal GC or CT versus urethral?
Well, in the United States, the only recommended treatment for gonorrhea, and well, I'll say gonorrhea because gonorrhea treatment includes chlamydia treatment, is an injection of ceftriaxone, 250 milligrams, and a gram of azithromycin pills, obviously taken orally. Some alternative treatments, if you absolutely don't have the injection of ceftriaxone for gonorrhea treatment, there's oral drugs similar to it. The problem is, and we participated in a study with Chris Hall in the state, which showed that if you give oral cephalosporins, namely cefpodoxime was what we gave, it only worked 75% of the time, and the cure rates for gonorrhea with ceftriaxone and azithromycin are extremely high, way high in the 90s. So that's really the only treatment patients should be getting for gonorrhea.
Okay.
And it doesn't make a difference if it's in their throat, their vagina, cervix, rectum, penis, it doesn't matter. That shot and those pills are the best treatment for all sites.
Okay, thank you. So we have a request to go back to the slide, methods for implementing site-specific testing. I think that's the graphics showing how the self-collection, I believe.
The bags of the tubes, or?
The slide number, I don't have the slide numbers here. Not that far back.
We'll get there soon.
Okay. Keep going, keep going.
Okay.
I think it's the next. Keep going. There you go. I think that's what was being asked. I'm not 100% sure. And then about the self-swabbing patient guide. So yes, there's two different requests for that. So we also had a question. Are you willing to share your slides after this session to be sent to everyone?
Oh, of course, of course.
Okay, so we will send those out along with the link for the recording of the session, so you'll have access to all of those. And then, let's see, how about, do we have any data showing how many HIV tests are ordered for individuals coming in for STIs tests or treatment?
In our facility or in other California facilities nationwide, or?
Let's go with your facility since you.
Yeah, I know data exists for, the state and the country. In our facility, it would be quite rare for a patient to come in for STD testing and not get an HIV test. I don't know when's the last time we looked at the numbers, but it's virtually all patients. Unless they say, oh, I had one last week at the Gay and Lesbian Center, all patients pretty much are tested for HIV.
So yeah, it's a very common practice. And I think that's fairly true in many places. Another question, what morbidity occurs for untreated asymptomatic GC or chlamydia in men?
Very good question. Comes up all the time. Well, you have to look at the two diseases probably separately and where the site of the gonorrhea or chlamydia is. With gonorrhea, obviously, usually it's just a discharge from your penis and some burning when you pee. If it's in the throat of the rectum, as you saw earlier, 85% of the patients have no symptoms. And if they were not to be treated, a large proportion of them would eventually clear the disease on their own, meanwhile spreading it to their other sexual partners. But gonorrhea I've seen a heart become infected with gonorrhea in my training. It can spread and cause what's called disseminated gonorrhea. You get these red, pussy, pimply things on your body, and it can cause arthritis as well. Now, chlamydia is interesting because, and we've seen 3 cases in the last 12 months, where the chlamydia of the rectum, undiagnosed and untreated, can, if it's certain types of chlamydia, can develop into a disease called lymphogranuloma venereum, or LGV for short. And certainly, so untreated chlamydia can cause that, which is a kind of a very chronic weeks and weeks of bloody mucus coming out of your anus, feeling like you need to poo all the time, but nothing comes out. Very classic syndrome. And then, of course, can't forget epididymitis, which is inflammation of your epididymis, which is a little tube connecting your testes to the rest of your urinary system. And epididymitis can cause enormous swelling of the testes and epididymis. Grapefruit-sized testes is not a very comfortable situation. Patients are always in the door right away for that. But it is easily cured with proper treatment.
Okay, one more quick question before we end. Are self-tests done in the office, or does the patient take them home?
You would have to do a whole other validation. Our validation is for the patient swabbing themselves in the clinic, and the specimen goes to the lab and is tested. If you don't know the temperature excursions that take place with the specimen before it's collected, you have to do a whole different validation. When counties have done mail-in specimens, like LA County did, you have to do a validation that if a patient does it at home, mails it in, leaves it in the back of their car for 3 days in the sun, is it still able to be validated? So it would just be a different kind of validation study, but it could be done. But we're not going to be doing that.
So let's do two quick things. Those secondary symptoms you talked about, how long does it take for those to start? Like
secondary symptoms, oh, these other things? Well, you have to keep in mind all of them are very infrequent. LGV, like I said, in our, we certainly probably have missed some cases, but it's a handful of cases a year. Disseminated gonorrhea is very unusual. Epididymitis is not rare. I would not say it's common. And the time frame, I don't know if anyone has studied the time frame on those, whether chlamydia causing epididymitis or gonorrhea causing it. I don't really know what the time frame is.
Okay. One quick last question. Mutually monogamous partners having multiple site sex, but they have not been tested before they were together, or since they were together. Would you test?
And you're talking about gonorrhea and chlamydia?
Yes. So, yeah, would you in that context recommend they test multiple sites?
I would say if before one becomes mutually monogamous, if one is appropriately tested at all sites and the relationship is truly mutually monogamous, there would be no reason to check them for STDs. It takes 3 people to make an STD, we always say. There's got to be another person. But I would say 98% of patients who tell me or tell us that they're mutually monogamous, when offered testing just in case the other partner isn't monogamous, every patient agrees to testing. Everyone says, well, I think he is having only sex with me. So it's a rare patient that'll say, oh, no, I 100% know he's not, and I do not want to be tested. I do not need to be tested.
So you're exploring a little further in getting some context. That sounds great. Okay,
Yeah.
well, I want to thank you, the Orange County team, for doing such a great presentation for us today. It was very informative and helpful. And as I mentioned to everyone, we will be sending out a link to this recorded session and the slides that were presented today as well for your reference. And please remember that we have 3 additional webinars coming up, one in October 26th and then the others a little later. And since you're on this list, I will be sending information about those as well. And if you have any other questions, please feel free to either call me or send me an email. My information is on the flyer and the other information that you received. Thanks again, Orange County team, Dr. Reed, Danielle, Colleen, and Alyssa in the background. We appreciate your help with this very much.
Thank you.
Thank you.
Okay, thank you all. Thanks, everyone.